Thanks for downloading the McKay interview. Professor Dr. David Heymann of the London School of Hygiene and Tropical Medicine is my newest guest. I interviewed him almost exactly 1 year ago to the day. How much has changed? Listen to what the professor says. Hello, everyone. Those of you who are regular listeners might remember that around this time last year, I broadcasted a 13-part mini-series on COVID-19. It was in the height of the pandemic and lockdown that I looked at the pandemic through expert eyes, not only in science and medicine, but also other fields like social psychology, organized crime, and religion. Almost exactly 1 year ago to today, my guest was an eminent epidemiologist from the famous London School of Hygiene and Tropical Medicine. He scolded me for telling you, listeners, about his impressive CV, and I teased him in return by saying that he had opened the door to a second invitation. And I promised him that next time my introduction would be briefer, a lot briefer, if only to save his blushes. Well, my guest is Professor Dr. David Heymann. You can Google him, and you'll find that he's one of the top specialists in his field. He's in London, I think, and we're on Zoom together. I run the risk of incurring his wrath a little, and I hope that he'll forgive me when I tell you that he is Professor of Infectious Disease Epidemiology at the London School of Hygiene and Tropical Medicine, as well as head of the Centre on Global Health Security at Chatham House. That's the celebrated Royal Institute of International Affairs in London. For those of you listening from the Geneva region, let me tell you that Professor Heymann spent over 20 years at the World Health Organization. That's where we first met. And before that was at the CDC, the Center for Disease Control in Washington, D.C. Hello, David. It's good to see you again. Many thanks for making time to be my guest on the McKay interview.
Thanks very much, Michael, and thanks for the kind introduction.
David, we have more than the 50 minutes allocated last time, and yet I'm sure the time will still just fly by. Let me start by asking you exactly the same question as this time last year. What is your current assessment of the current status of COVID-19 across the 5 continents? If my numbers are correct, that's over 164 million cases. It was 4.7 million when we spoke last year, and over 3.4 million deaths. It was 300,000 deaths. I nearly said only 300,000, but it's 300 is still a big number, but 3.4 million deaths as we speak today. Are my numbers more or less correct? And please give me a quick overview on how you see the situation in Africa, because we don't get a lot of news out of Africa. In the Americas, is the United States out of danger? I read that Canada has not learned as much as it should have from SARS. Mexico's also suffering. Brazil is in a bad way, and Chile seem to be difficult reports. Asia, we know what's happening in India and Pakistan, but do you know more about what's going on in China and more recently in Taiwan? Briefly, Australia, New Zealand seem to be success stories. And finally, home base, Europe and the British Isles. And I shouldn't forget Russia. Very briefly, an overview, David.
Well, thanks, Michael. And you know, this infection, most epidemiologists feel that it's now becoming endemic, which means that it will be with us for quite a while, or possibly for a longer period of time. So we need to count on this disease as being with us. We need to learn to do our own risk assessment, and we need to, at the same time, after we've done that, think if we would be able to infect others had we been infected and who might be exposed to us. So we should know how to protect ourselves and protect others. And that's the way we have to move forward. It's very tough in some countries where the government has made these decisions for people, and now they're on their own to make their own decisions. But that's where we need to get to, is understanding how to deal with this infection as we deal with TB, as we deal with sexually transmitted infections, HIV, risk assessment of our own risks, and then mitigation of those risks, either wearing a mask to protect others or doing some other measure that will protect others. So that's how we need to go moving forward. What you said about the cases is very important, because cases really are infections. They're not all sick people. What's more important is those deaths that you reported, and that's the tragedy of this disease, is that there have been many, many deaths. And they will continue, unfortunately, until either the virus decides that it will mutate in such a way as it's less virulent, or the populations are vaccinated. And we're very fortunate. We have vaccines, we have diagnostic tests, we have therapeutic agents, we have everything we need to deal with this outbreak now, and we need to do that moving forward. We've seen that countries in Asia have done quite a good job early on in this outbreak. They were alert. By the 20th of January, countries in Asia were detecting outbreaks and stopping them and preventing the disease from spreading into communities. Whereas in Europe and North America and many other parts of the world, they just seemed to watch and see what would happen. They were having outbreaks as well, but they were waiting to see what would happen. Yeah. So it was very unfortunate that they hadn't had the experience, possibly, that the Asian countries had with SARS. And so they did a good job, and they're still doing a good job. But this virus, as I said, is becoming endemic. And countries like Australia and New Zealand, which have kept it out to date, or done a pretty good job at that, will have to at some point open up, and that disease will likely come in. So what they need to do is make sure they have vaccinated the populations they feel they need to vaccinate before they make that leap into letting the virus enter. This virus will not be eradicated. It's with us, and it will stay with us.
Can I just ask you a question which puzzles me, and I'm sure it must puzzle ordinary people like me listening in. When you use an expression like this virus decides, it's almost, you talk about it almost as if it's a sentient being, and yet, of course, it's not. And even I have a friend of mine who's a distinguished biologist. He said a virus isn't actually a living thing. So what do you actually mean if the virus decides to X, Y, and Z?
Well, it's really a principle in personalizing the virus, but the virus might mutate in such a way that it has an advantage to infect humans. It can infect them even more easily, or it can escape vaccine, and therefore it would have decided that it can do a better job at becoming endemic than it does at present. So I just have personalized the virus. It doesn't make that.
Yes, I realize that, but I was just curious because sometimes the language of describing this virus is rather puzzling to people who are not scientific. You know, look, my next question: when we talked, you remember I mentioned the Donald Rumsfeld-ism. We talked about known unknowns, and you told me then, last May, that scientists knew quite a lot about the COVID-19, but also that there was still a lot to learn. Tell me in simple, non-scientific language, David, what we still do not know, people like you do not know, even as we have many vaccines to choose from to save lives, which we didn't have this time last year.
What we don't know is how long that immunity, that protection from the vaccines will last. We don't understand how long immunity from natural infection lasts after infection. And what we don't understand, and what the big risk now is, the mutations that are occurring, because this is an RNA virus, and all RNA viruses mutate to a certain extent. This virus, the more it has an opportunity to transmit, the more it will mutate in individual people. And some of those mutations will make it what we call more fit to transmit to others. Some mutations may make it less fit, and it may die out in some populations. But the virus is constantly changing, and it can change in a way that it becomes more easy to transmit from person to person or less easy, and it can change in such a way as to become more virulent or less virulent. So there are many things that this virus could do moving forward.
So to put it in simple language, so research specialists have to be following many different avenues as the virus itself follows many different avenues in order then to eliminate the possible further mutation.
We can't limit further mutation, but unless we can decrease the people who are infected, because
yes,
when it replicates, it mutates. What we can do, though, is make sure that the viruses are still not escaping protection from the vaccines that we've used, or from people who are immune from previous infection. And so that's another issue that has to be addressed. We need to know what those mutations are. We need to then look at how they're acting in human populations, not only how easily they transmit, but also whether or not we're still protected from our vaccines.
And this is a transnational approach going on in laboratories all over the world.
Absolutely.
Yeah.
It has to be established. It's not yet fully established. We can't leave gaps in our knowledge by not making sure that every country is participating.
Great. Another professional question. As a medical specialist, David, were you surprised by the speed with which vaccine solutions were found and then approved by governments? I mean, what's your view on how it came to pass that a normal 10 to 15-year period of bringing a new drug to market seemed to evaporate and then, thank God, ended up being less than 2 years? So please explain because you know that there are people out there, a minority, thank goodness, who are suspicious of the short time frame and use that as a reason to decline the vaccination. What's your view on that?
Well, I think it shows how the world can pull together and really do something very rapidly if they need to. And
Absolutely.
it's been quite incredible to see the number of vaccines, as you say, Michael. What's also important is that there are new ways of making vaccines that never were used before. And these have opened up new doors for many other diseases as well. So all of this research in vaccines has been remarkable.
It's amazing. And just a quick question on behalf of a friend of mine I was just chatting to yesterday who contracted COVID some months ago and was quite ill. I'm not sure if he was in intensive care, but he survived it, obviously, because he phoned me yesterday. He had a first vaccination, went back for his second one, and the doctor here in Switzerland said it wasn't necessary to have a second vaccination. And he was just puzzled to hear that from the doctor, although I think he had the second vaccination in the end.
Well, the doctor was thinking about the fact that if he had COVID, he would have a good antibody and immune response to the virus, having had the infection. So what this doctor was obviously thinking is that that served as his first vaccination. And so a second dose would be, or a first dose of vaccine would actually be a second dose.
I see.
But I think he was right to give that second dose and to continue to give vaccine to the full requirement of the companies that make these vaccines because they know what's best.
Yeah. My guest today is Professor Dr. David Heymann of the London School of Hygiene and Tropical Medicine, and we're talking about COVID-19, the pandemic, 1 year on from the first time that I had the privilege of interviewing him. Let's talk again a little bit more about variants and whether these variants will result in populations having to receive vaccines annually, rather like my wife and I having the flu vaccine. And let's start with the Indian variant. What's your opinion about that?
Well, Michael, so far, the Indian variant has not been shown to escape the protection offered by vaccines. So that's good news. There's also other good news in that the vaccine manufacturers, those who have developed these vaccines so rapidly, can make changes to their vaccines, especially the mRNA vaccines, within a very short period of time. We're talking about 6 weeks until they can adjust their vaccine for a new strain if they need to, or a new variant. But at that point, then the issue will be production capacity. And that's the bottleneck today. We have a facility called the COVAX facility, which is set up to give equitable distribution to vaccines, but at the same time, the production capacity can't meet the demand.
Okay, well, as you've mentioned, COVAX, let me just go to that particular question because I had that on my list of things to ask you, David. About a year ago when we spoke, you stressed that the real issue, once a vaccine was discovered, was to ensure its fair distribution. I remember your words very clearly. I'm aware of the COVAX project. You've just mentioned it again for countries that cannot afford the vaccines on offer and where population density is high in urban areas or else quite sparse where people live in remote areas. But please share with me your experience on the sheer scale of the project and what we, looking on from a distance, need to watch out for. And your view, given your experience with SARS and Ebola, would be invaluable here.
Well, the COVAX facility is an effort to make more equitable distribution of vaccines. And their initial allotment of vaccines will be 20% of the national requirement to countries around the world that can't afford to buy vaccines. And those vaccines will be destined for the health workers and for populations at risk.
And just to stop you there, the WHO is the arbiter of who falls on which side of the line. Is that correct?
It's a partnership between WHO, UNICEF, Gavi, which is the Global Alliance on Vaccines, and also the Collaboration for Innovative Response to Epidemics here in London. So there's a whole group of who are involved. And those organizations review the requests from countries to make sure they're sound requests and that the government is willing to provide the people necessary to give the vaccines, and then the vaccine is released. But as I said, the problem is not getting the vaccine, it's the production. It's not purchasing, it's the production capacity to make vaccines present. It's the bottleneck.
I see. Talk about the elderly and the frail. We know that the elderly and frail with underlying health conditions paid a very heavy price in loss of life. But how is it, David, that the virus now seems to attack an increasing number of younger people in their 40s or even younger? Or am I misinformed about that?
Well, it is causing infections in all populations, and the proportion of younger people who are vaccinated, the numbers are much fewer than the elderly population. So the virus has to circulate somewhere, and that's where it circulates. Fortunately, younger people to date haven't had any more serious illness if they don't have the comorbidities or obesity that causes these serious infections. So they get infected. Some, unfortunately, have long COVID, and that's what we don't really understand yet. But in essence, the people who are getting infected, if they're younger in general, if they're in good health, don't have serious illness and a risk of death.
So essentially, because the body is young and relatively speaking, healthier and stronger than their parents or grandparents, they don't provide the sort of the appetite, the feasting ground for this virus to succeed in. Is that what you're saying?
Well, I'm saying they are a feasting ground, but because their immune response is probably more robust than the elderly, they do have a shorter period of infection and less serious illness.
Yeah, I see. You mentioned at the beginning of our conversation about the way we behave, because we have to get used to dealing and living with this virus now for the long term. How, in your opinion, should our social behavior change, even now as the apparent danger in many countries seems to be reduced? I'm particularly thinking of things like close proximity to family members, hugging, signs of affection, shaking hands, which has now been almost outlawed apart from elbow bumps and knuckle bumps and all that sort of stuff. But it's a serious question. I'm not being flippant, David. But how do you think we will now need to modify that social behavior with masks and with the way we distance ourselves from people, that not even the ones we're close to, but just in our general social intercourse with people?
Yeah, well, again, the transmission of this virus from person to person depends on three things. It depends first on the virus and its characteristics. It depends on the immune level of the population, whether they've had exposure to the virus or vaccine and whether they're protected. And it also, the third issue that it depends on, let's see, it's the transmissibility of the virus, it's the population immunity, and it's also the proximity of people one to another, their behavior. And so if you can modify your behavior, then the transmission won't occur. So paying attention to the distance between people and mask wearing to protect others, a whole series of things is very important right now because the virus is still circulating at significant levels. As time goes on, transmission may be less. We'll learn to live with this virus. The population will have more immunity either from natural infection or vaccine. And gradually, I believe our behaviors will change back to a more normal way. But some people may not want to start embracing again. They just think it's maybe easier not to do that.
Yeah.
And so it may be that certain cultural practices will be modified for the long term just because people have found it more convenient or less of a burden to do.
And the fact that we've had a vaccine or two, like I have, doesn't mean necessarily that I should behave in a way that's maybe less responsible than before I was vaccinated. Is that correct?
That's the belief of most scientists. However, the US has just said that if you're vaccinated, you don't need to wear a mask.
I saw that, yes.
They're saying that because there is, in some instances, people who are vaccinated, there is a possibility of them carrying the virus in their nose, but it's at levels that don't appear to transmit. And so that's why the US has made this recommendation. And again, everybody is building the ship while they're sailing, and we'll see whether this is really something which is effective or which is not effective. So we just have to watch as time goes on. And fortunately, there are monitoring systems in place to say whether or not this is a safe practice.
It's a nice expression, David, building the ship while we're sailing. I like that one. I must remember that one. Listen, David, last question. It's an impossible question for you to answer, but I'm going to ask you anyway, because you're a doctor and you're a nice man to talk to. You must surely be asked by non-specialists like me, when will we be safe, Professor? How do you answer that question?
Well, individually, we'll be safe as when we get the vaccine. And until we get the vaccine, to be safe, we have to physically distance from others, and we have to make sure that we wear masks to protect others when we're on crowded situations and can't physically distance. So continuing to wear a mask on public transport is very important. Continuing to wear a mask if you feel that you're going to visit elder people somewhere and you don't want to infect them, even if they're vaccinated, because remember, these vaccines are only 95% effective. 5% of people will get serious illness from the vaccine, even if they're vaccinated. So we just have to make sure that we're practicing good public health measures to protect ourselves and protect others.
Well, before we close, David, because in a way you've opened another interesting area which we really haven't explored, but you, with all your experience and years practicing medicine, you must have come across people, the anti-vaxxers or whatever you call them. People have doubts, the doubting Thomases. Just on a personal basis, what do you say to these people? When you come across them, how do you go about trying to persuade them that this is not just for them, but it's also for the greater good of the society in which they live?
It's a very difficult issue, the anti-vaxxers, and there are several types. There are the hardcore who will never accept a vaccine of any type, and those you really have difficulty converting. But there's a whole fringe around them of people who are attracted to their messages, who you can influence, and you can help them understand that vaccines are good for them, their own protection and for the protection of others. So that's the target populations, and there has to be a face that's trusted, that's telling people to get vaccinated. You can't just force vaccinations on people. They have to understand why they're getting vaccinated, and that's best if there's trust between the person who's talking with them and the persons who are the anti-vaxxers.
So you wouldn't advocate compulsory vaccination for adults?
I don't think anybody will advocate compulsory vaccination. They may try to incentivize vaccination by requiring vaccination to go to certain areas of the country or certain festivals or something to that effect. Countries may decide that they want to do that. That would be an incentive for others to get vaccinated, but there would also be pushback.
Thank you, David. Many, many thanks for making time for me and our listeners and for answering all my questions with such patience. You must be tired of listening to ordinary folk like me asking these questions. Wish you continued success in the great work you do, David. And I thank you very, very sincerely for making time for me. My guest today has been Dr. David Heymann, Professor of Infectious Disease Epidemiology at the London School of Hygiene and Tropical Medicine. Thank you again, David.
Thank you, Michael.
Thank you for listening. Please share the show with those around you, and if you have any questions or feedback, write to me at contact@mackays.ch. I promise that I will reply to you.